So good morning. I do feel like it's I feel like we just had such a long break. I know y'all probably feel like you wish it was another week or two. But I hope that's not true. I hope you're excited to finish this up because you guys probably finishing up A and B. We're going to finish up maybe the respiratory system today. If we don't finish, we'll easily finish it next Monday. So I had promised you guys that on this next test that it would just be the lymphatic system and the respiratory system. I do hope people have been kind of reviewing the lymphatic system. There's a lot of information in there, and as I was telling you guys before, I think a lot of that information is new to people because it seems like the lymphatic system is a system that you haven't heard much about, right? So just as a quick review, you would make sure that you want to know any of the important structures that we talked about in the lymphatic system. You would want to understand their functions completely. You would, that means like the vessels themselves, the lymphatic capillaries, what lymph is, the lymphatic capillaries, the lymph nodes, the tonsils, the spleen, right? So you would want to know all of that. But you also, we realized most of that chapter is talking about immunity. And in that chapter, we talked a lot about innate or non-specific immunity, which is one type. And then we talked about that very specific immunity that we also sometimes call adaptive immunity, right? And all those cells and all of those things that are involved in that go back, you will be asked questions. They're guaranteed that you'll have to match functions to cell types. You'll have to understand humoral versus cell-mediated. You'll have to understand the different classes of antibodies. So is that sounding familiar? Did that jog everybody remembers now what class we're in, right? You're hearing that. Okay, so that's the lymphatic system. Please be sure to also be looking at the deeper insights and the disorders because, again, this test is coming up soon. I don't think it should be next Wednesday. So unless y'all would want it then. Would you want the test on the respiratory lymphatic next Wednesday, a week from today, or would you rather push it back?
I mean, if you finish it today, I would say so. But
okay, well, listen, we'll see. By the end of today, we'll make a decision because I like to give people at least a week's notice before a multiple choice test is coming up. Because as y'all know, tests carry more weight than some of the other things that are going on in here. So anyway, so let's just go ahead and keep going with the respiratory system. We said, what's the major stimulus for you to be breathing?
I wanted me to remind you about that.
Okay, I have it. Thank you. That's exactly what Ricky gave me too, because I know y'all are worried about me, and you should be. So, no, but thank you, because I need to remind of where we ended. And that's where we're going to stop at. But tell me, why are you breathing at the rate you're breathing? Ventilation, we said, is referring to one inspiration, one expiration. One breath in, one breath out is one ventilation. How many times are you breathing in and out a minute as an adult at rest? 12 to 20. 12 to 20, which is kind of per minute, which is a huge range. But it doesn't mean that you at rest are always at 12. You're going up and down. Is that right? And what did you tell me the major stimulus for you for that rate? What is driving it unless you're being suffocated for some reason? So if you're not drowning or if you don't have a respiratory disease, what is the major stimulus for you to be breathing at the rate you're breathing? Is to regulate your pH balance. And it's really the cerebral spinal fluid. That pH is being monitored by the central nervous system, part of your autonomic nervous system. And what we said, I'll write this on the board because for people who aren't here, sorry about that, you won't be able to see this. But anyway, so we said we have this understanding that the nervous system sets all of our set points, don't they? And when we think about pH, we know 7.35 for most body fluids, 7.35, and what was the high? And these are still normal. All of this would be normal within normal homeostasis. Is that right? So, for set points is 7.4. And so as long as we can stay in this sort of pH range, this is for blood and interstitial fluids and whatever, then we're not for all fluids, but for the main fluids, this is going to be great. And so how does the respiratory system play a role in that? Is that, sure, every time you breathe in, you are bringing in some oxygen, but every time you breathe out, it's important too, because you're getting rid of CO2. So every breath you take that you're getting out, you're breathing out, you're getting rid of CO2. And I want to remind you all of this equation. You will need to know this equation. I think you already know what CO2 stands for, carbon dioxide, right? And plus water. Is that right? If they're building up in the system, your system is going to convert those quickly to carbonic acid. This is carbonic acid, which it doesn't stay like that long. It gets changed to bicarbonate and hydrogen ions. And you all told me that you understood that the concentration of hydrogen ions is called what? Knowing your what? It's knowing your pH. Is that right? Everybody go with that so far? So let's think about breathing here and your rate of breathing, okay? So you're thinking about your rate of breathing. And you understand that if you are at 7.35, do you want your pH to go up or down? If you've detected that, if your nervous system's detecting that it's at 7.35, do you want your pH to continue to go down, or do you want it to come back up? Okay, so you want it to come back up. And when we talk about it coming back up on this scale, is that becoming more alkaline or more acidic?
Going up is up.
So if it's, does everybody remember the scale? So we remember the scale, right? And we said that this is acidic. It's becoming acidic the lower the numbers on 7. And this way it's becoming what? Alkaline or basic, right? But what we knew from this scale that we learned last time was actually as the numbers are decreasing, we said the amount of hydrogen is doing what? Increasing, because this scale is inversely proportional to the amount of hydrogen. So as the number on the scale is increasing, we said that actually the amount of hydrogen is what? Decreasing. Because we said pH, yes, it's the percent, the concentration of hydrogen that's present, but we also knew something else about it. It's the negative log, right? And negative meant that this scale is inversely proportional to the amount of hydrogen ions. So the lower the number's going, it means that you're getting more hydrogen ions. So let me say this to you. If you're needing to make your pH go up, if you're needing to make your pH go up, if you're needing it to become more alkaline, it means that you're needing to do what to your hydrogen ion concentration? Make it go down or make it come back up? Yes, so you're needing to get rid of hydrogen ions. So looking at this equation, does it, and this is why you need to know this equation, because you need to be thinking about it. How much hydrogen ions? Do I need more of them or do I need less of them? And you're telling me that if your pH is dropping, you're going to need to bring it back up, which means you've got to get rid of some hydrogen ions. How do you get rid of it? Just by increasing your what? So you're I'll just do it this way. You're increasing your rate of breathing here. If you start blowing that hydrogen off, is your pH going to come back up? Is it? I have some people who have zoned out on me. Can you come back to me, please? Because you do need to know this. One of the biggest things, and it's one of the hardest things in nursing or any kind of physiology med surg that you'll do, is something that you have to understand about acidosis and people going into alkalosis as well, and how their respiration's affected. So increasing the rate of breathing is going to make you become more alkaline, which means you are getting rid of the hydrogen ions. Does that make sense? Does it? You do have to be thinking about this negative log and what that means to the concentration of hydrogen ions. So now your nervous system is detecting that you're at 7.45. Do you want to get much higher than that? No, the nervous system's going to send a signal to the pons and the medulla of your brain. What do we call those parts of your brain? The pons and the medulla where your brain stem. It's your brain stem where breathing is controlled and blood pressure. Isn't that right? So when you're getting kind of alkaline, your brain stem is going to get a signal to do what to your respiration rates? Slow the rate of breathing down, because if you slow the rate of breathing down, what will start to build up in your system? What will start to build up in your system? Hydrogen ions. Do you get that? And as hydrogen ions build up, actually the number on the pH scale is going what? Down. Are you good with this? So now you're low, and then your respirations will start to slow. It will increase again, and then they will slow. And you just do this without having to think about it, don't you? Because your autonomic nervous system is controlling pH. Your respiratory system is the major player and as a buffer in your system in controlling pH. How many of you know people with diabetes mellitus? So some of you know people. Have y'all ever heard of brittle diabetics? Do y'all know what that means when you hear about brittle diabetics? Does anybody know what that means? What does it mean, Jay?
Well, either they're really low or really high, and you can't really, the insulin, you just don't know whether to give or not give.
So a brittle diabetic,
Dying their sleep.
scare the hell out of you. That's what they do, die in their sleep. It's nothing funny about that. I laugh when I'm nervous. Y'all know that about me now. So look, but no, here's a really sad thing. It's true. So brittle diabetics, they stop kind of responding the way that you want them to respond, and sometimes you think they should be responding. So it's really, they're having a hard time controlling their highs and a hard time controlling their lows. And, you know, if something doesn't really change drastically about that, they're not for this for long. So brittle diabetics. And the reason I bring up brittle diabetics, period, is because we understand that diabetics can't really use glucose to make ATP, so they'll often use what other organic molecule to make ATP? So they will burn what for energy? Fats. They take all their carbs and turn them to fats, because then their body will then use the fats to burn as energy. But what did we say about fats being burned for energy? What will be given off? Ketone bodies, which are going to put a person into something called, and y'all need to know this, write this down. We'll put this person into, because I'm going to talk to you about this, and you need to know it. This is called ketoacidosis. Ketoacidosis. So when somebody's in ketoacidosis, is their pH off, do you think? Mm-hmm. And what do you think about their hydrogen ion amounts? Are they low or are they high? If they're in acidosis, their number is going what on the scale? You got to know the scale. This is a 7. In case you didn't know, that's a 7. The numbers going down on the scale. The numbers going down on the scale. So what will end up happening when somebody is in acidosis is that what you'll see them doing, and they'll be getting lower than this even, but what you'll see, and their body kind of takes over this. Have y'all heard of Kussmaul respirations? Kussmaul respirations is something that diabetics will tend to get into, and they'll do this. Sorry, that's what it sounds. It's really rapid, deep breathing. And why do you think that makes sense that they're in that? Because they're trying to blow off what? They're in acidosis. What are they trying to blow off? Hydrogen ions. And they'll do that. They'll do that in their sleep. And you know, they'll do that. Actually, sometimes, I mean, that's subconscious, but sometimes you might want to get them to do that. Do some quick rapid breathing for me. You know, especially if they look like to you, they're in a sort of a scary state or whatever. But anyway, Kussmaul respirations. So the main stimulus for breathing, unless you're drowning, or unless you have acute respiratory disease like pneumonia, or unless you have a chronic respiratory disease like COPD, which you all know stands for chronic obstructive pulmonary disease. You should know that, COPD. Unless you have that, in normal situations, it's pH. And absolutely, I think it was Dylan maybe who said, that is related to also what level? CO2 level. But it's more directly related to hydrogen and pH, okay? Now, any questions for me about that? Y'all have any questions for me about that? I will ask you a couple of questions on this next test and maybe for the quiz Monday, or is it quiz, lecture quiz, to explain this to me, and I want details. I want details about what happens when pH is low, how that will affect your breathing, how will it affect your hydrogen ion concentration, and what will happen when your pH gets toward the high end of the scale. What will happen to your breathing rate, what will happen to your hydrogen ion thing. And I don't want you to memorize it, okay? I want you to really know it. So good. Now, so we're going to talk about respirations. And guys, you see this picture here? I want to tell you, I want to take a minute because instead of giving you, I don't think y'all need this, we don't need this at this time. But I'm going to give you the structures you need. So write these down. I'm going to give you the structures that you need for this respiratory lab. That will be the same day that you take the lymphatic and respiratory test. This will just be a labeling of these major respiratory structures. And, really all of these structures need to be functioning kind of properly because many of them are helping to conduct air, which means just moving air. And some of them are responsible for actually where gases get moved and diffused into the system. But let's look at these structures. And this picture is probably not a bad one to look at, so y'all can do that, but I'm going to add a couple of things to this picture because I have to. The most obvious thing I want to add first is the name of this dome-shaped muscle, because this dome-shaped muscle is one of the most important muscles for inspiration. And what is that muscle? Diaphragm. So make sure you could label the diaphragm and spell it correctly or it will be wrong. So the diaphragm. Absolutely, because we know this diaphragm, you don't see it in this illustration, but the diaphragm has these connective tissues that are holding the base of the lungs to this diaphragm. So as the diaphragm contracts down, what's it pulling with it? The lungs. So the lungs have to have this ability to change shape, don't they? This is why someone can die if they're being, squeezed too hard. Or, trampled, or if there's something, that's not allowing their chest cavity to move. So absolutely the diaphragm is one of the major muscles. Now, obviously you'd want to know the right lung and the left lung. Okay, so that's an obvious thing that you'd want to know. I do want you to tell me right now, do you think even from this illustration, which is a pretty good illustration, are the lungs symmetrical? No, you don't think they look symmetrical? They're not mirror images of each other? They're really not. The right lung has 3 lobes. And the left lung essentially has these 2 lobes. And this left lung, if you'll notice, it looks like it has a little cutout right there. Do you see this left side? It looks like it has this little notch cut out. It's actually referred to, and you would want to label it, the cardiac notch. Why do you think it's called the cardiac notch of the left lung?
The heart notch sits there.
Because the heart is sitting here. And the heart is compartmentalized with all those layers we learned. What's the outermost layer? The pericardial sac. And inside that sac is fluid. And then it's the epicardium. And then, that's the outer layer of the heart sitting here. So we understand that heart is sitting right there. And this is a natural, normal structure of the left lung is this cardiac notch. So you want to be able to label that. I want you to see from this picture, which I think is in your book too, but anyway, I want you to see from this picture that we do see, and this is not labeled on your picture, but I do think that you should know that the top peaks of the lungs here are called apexes of the lungs, the right apex and the left. These apexes are actually slightly above the collarbone, the clavicle. Do y'all see that? Can y'all see that in this illustration? That this is actually just slightly peeking over the clavicle here. So this is, again, why somebody can come into your ER that's had a injury, and they think it's an injury to their neck, but are you worried about their lungs? Might you be worried about their lungs? You can have people come into your ER that have injuries to the neck that have a collapsed lung. And it's because of this understanding, this anatomy here. Okay, so these are the apexes of the lungs. And we see this structure, this hollow tube that looks like it's coming down and separating out here. This is the trachea, and you would certainly want to know the trachea. You want to know that where the trachea first breaks off to the right and left sides, this is called the primary bronchi. These are the primary bronchi. So primary means what? First. Where the primary bronchi breaks off, what do you think we call that in its label? Well, no, it's the secondary bronchus. This is the secondary. Bronchus is singular, bronchi is plural, right? So, and where the secondary breaks off, what do we call those? Tertiary bronchus. No, so these are hollow tubes that stay open. Let me tell you why they stay open, and you don't have to label this, but do you all see in this illustration, and you'll see even on your little rat, when you dissect the rat, you're going to actually have to remove the trachea and keep it, try not to hurt it too much, because you're going to remove it with the bronchi and everything in the lungs, and they're going to all come out. It's one little section, right? But you'll see, even on your little rat, that the trachea stays open. So the reason it stays open is that there are these cartilage C-rings. And these, do y'all see how they look like little bands there? Because we're just looking at it from an anterior view. But if we were to look at it from the back view, we would see that these are C-rings, cartilage rings. What do you think? Oh, it's telling you. What is behind the trachea is a muscular tube called the esophagus. What do y'all know the esophagus does? What's the function of the esophagus? Does anybody know? So it is a muscular tube that is going to transport liquids and foods to your stomach from your mouth, right? How many of you have ever had and this is why these cartilage rings aren't completely circular, because this muscular tube is behind it. How many of you, and that muscular tube, when there's food or water in it, needs to be able to expand some. How many of you have ever swallowed something before you really got to chew it well enough, and for a split second you thought, I couldn't breathe. You can't breathe, right? Has that only ever happened to me? Thank you. Okay. So if it's never happened to you, you've probably never been hungry. So, I don't know. But whatever. The reason that there's C-rings is because the esophagus does need to expand sometimes, and because it stretches. It has to stretch when there's food coming through. So that kind of allows that to happen. But if there's too much, then it can actually make you feel like for a second that you're choked. But anyway, usually it moves on down because the esophagus is muscular and it's going to move substances along. So, okay, any questions for me so far? All right. At the top of this trachea, there's this area and it's really this whole little area here, and this has been dissected for you, a coronal dissection, but this is called the larynx, and it's what people call the voice box, right? The larynx. So if you've ever heard of laryngitis, what do you know is involved there? Well, but what's itis at the end means what? And laryngitis means? Exactly. All right, now, and speaking of that, I can do a little other here. So what is bronchitis, do you think? Inflammation of the bronchi. So that would be inflammation of bronchioles, or the bronchi, right? Now, there's also these structures that we can't see here because they continue to divide, continue to get smaller and smaller, more numerous, that are called bronchioles. Bronchioles are really getting tiny now. What did I tell you a lumen is? What's a lumen? It's the inside of a structure, right? So so as you've got bronchi, primary to secondary to tertiary, what's happening to the lumen? Getting smaller and smaller. And then when you're in bronchioles, is the lumen really small? But still need to be big enough and open enough that air is moving, being conducted, right? So people can have bronchitis, which is of these larger bronchi, or they can have bronchiolitis. So bronchiolitis is going to be even these smaller structures where gases really need to be moving into what's called the alveoli, which we'll talk about later, alveoli microscopic. But any problem so far? Okay. Now, I do want you to understand that the lungs have this layer around them. They're compartmentalized just like the heart is. And this is referred to as the pleural cavity and the pleural lining. Have you all ever heard of pleurisy? Have you ever heard of pleurisy? Has anybody ever had pleurisy? Been told they had pleurisy? Nobody? Good. Bye. Have you ever known anybody who had pleurisy? It's not that uncommon. So pleurisy is going to be inflammation of that pleural lining. And patients are going to be coming in telling you that they don't feel like they can take a breath, that it feels like somebody's stabbing them like a knife in their chest. And so pleurisy can feel like that because of that inflammation in that pleural lining. It's usually viral. And so you're going to try to help the signs and symptoms of that until they recover, whatever. Are we good? So that's what that's referring to. And again, why do we have that? Because the lungs need to get what? They need to be able to expand and contract. So they're compartmentalized with this fluid layer for the same reason that we saw the heart have the pericardial fluid. Because as the heart's having to change shape and structure, does that reduce friction? It also sets up a pressure gradient that allows for the lungs to fill up with air. If there's ever a breach in that pleural lining, then the lung is going to collapse. I'm going to give you this. I'm going to give you this before we get to it, but it is in the slide here. Has anybody ever heard of somebody having a collapsed lung for whatever reason? Has anybody ever known it? Okay, so if trauma happens, and I told you it can happen even up here in the neck, or somebody can fall off a step ladder, and 2 weeks later they're just like, God, I don't have any energy. They go into the emergency room because they're not feeling good and have an X-ray, and they say, you have like half your lungs collapsed, one of your lobes is collapsed, and what did you do? And they'll say, well, 2 weeks ago I fell off the step ladder, or I slid down my steps, or I did something. And it just happens slowly. Now, if it happens slowly, your bodies are amazing things. And when things happen slowly and come on slowly, the body tries to acclimate to it. And that's the only reason they're sitting and talking to you in the ER. But some people can have spontaneous collapse lungs. They're called pneumothoraxes. And y'all should know that word, pneumothorax. A pneumothorax is a collapsed lung due to a loss of the pressure gradient in the lung, and a loss of pressure gradient, and the lung will collapse. So anytime there's a collapsed lung, that's a pneumothorax, you're going to have to put in a chest tube. That chest tube, they make an incision between the rib wherever the lung is collapsed. They make an incision and shove a tube in there. And that chest tube is going to have to stay in until that lung can, you can get rid of the fluid in that area, and that lung can reinflate. And then as soon as they feel like it's safe, they'll pull the tube. By the way, no numbing for any of that. So because they just feel like the numbing, that the procedure is a quick procedure, and might as well just do it. Usually getting the chest tube in is an emergency procedure. But pulling the tube out, they don't. As far as I know, they're still not numbing that when they do that. It's called a pneumothorax. It's a collapsed lung. It can be due to trauma. It can happen spontaneously though too. So it can happen over a period of time, or it can happen spontaneously. The people that it happens spontaneously to, they don't get the opportunity to talk to you because they usually have passed out because their body hasn't been able to compensate for it, so they end up passing out on you. And then, you have to figure it out. Some people have spontaneous pneumothoraxes and no trauma. People who have spontaneous pneumothoraxes have a much more likely chance of having them than someone who's never had one. And I do think there is a familial thing associated with spontaneous pneumothoraxes. Does anybody know anybody who has spontaneous pneumothoraxes? No. My first roommate in college, I was 18, I'd never heard of pneumothorax. Ronnie was her name. She had one. My freshman year of college, had one, and completely passed out and whatever. And so we got an emergency note. She said, "Oh yeah, I forgot to tell you I had those sometimes." Really? So I was like, God, I think she had like several from the time she hit puberty on. So she just was mad. Spontaneous pneumothorax. Usually you're going to see people having those because of trauma. There was some history of trauma. Now, the trauma can be acute, like gunshot wounds or car injury, or it can be slow. Yeah.
So there's open and closed. So would the open one be like where you can see it, or like?
So I don't know exactly how you're referring to that. I think you're referring to something like a trauma that's open. So it's a really obvious thing, like a gunshot wound that's going to cause a pneumothorax. So I think that's how you're kind of classifying. And that's certainly, if you see somebody who's had an obvious open wound to the chest, that's your first concern, is that the lung's gone. And it's going to be an emergency, obviously, procedure. Where other times it can just be a trauma that's like what am I trying to say? Not a contusion, but kind of like that. And it doesn't have to be spontaneous. It can happen 2 weeks later. It can be really slow. I want you guys to write down a word that your textbook doesn't really, your textbook links these kind of together, but it's wrong to do that. You won't hear it like this. Write down, because this is also a collapsed lung, but the word is atelectasis. Atelectasis, this is going to be A-T-L-E-C. It's going to be in your notes in a minute. Atelectasis. This is a collapsed one too. But this lung is collapsed because something is blocking the airway. So y'all are seeing this illustration, but do you understand there's also arterial blood supply, there's venous blood return, there's lymphatic system vessels, right? We understand we're seeing this all nice and clean, but are there a whole bunch of other structures here? How about lymph nodes? Are they here? Yeah, so there's all kinds of stuff that's supporting these tissues. In an atelectasis, it's usually because of an obstruction like a tumor. Or it can be a lymph node that has become so, lymph nodes can get big, can't they? It's a lymph node. And so it's gotten so large that it's blocked airway past that point, and that part of the lung will collapse. Do you get what I mean? Will putting a chest tube in help that? No. No, that's not going to help that. So you do have to figure out what is causing pneumothorax, right? So atelectasis and pneumothorax both mean collapsed lungs, but they do mean collapsed lungs for very different reasons. An atelectasis is usually because of a blockage like a tumor and or a lymph node. You usually don't have any foreign thing in there because that's usually an acute thing too. So, okay, so this is the larynx. And at the top of the larynx is called the glottis, which is really the opening, if you will, to the trachea. And on top of this is called a little cartilage flap of tissue called the epiglottis. Epiglottis. What do you think, and this isn't the greatest picture of an epiglottis, we'll see it in a second, but this is a little cartilage flap that covers the glottis. What do you think its function is? Well, if it's open, then air can move in, right? But why would it ever want to close?
In your airway.
You don't want food and water in your airway. And we've all had that. Food, for a second, food or water, and you choke immediately, don't you? That's like a reflex. that you're going to get that out, right? So this epiglottis is wonderful, and it usually works. And so we're really happy about it. But I need for you all to know that something about this. This can become inflamed and infected. And what would we call that? Epiglottitis. That's exactly right. Epiglottitis. Now, here's the wonderful news for you as health professionals. You will probably never have to watch somebody die from epiglottitis. There's essentially only, I shouldn't say only, because whenever you say only or always or never, that's never true, right? I just said never again. But anyway, epiglottitis is usually caused from one thing, and it's a bacterium. And I want you to know that bacterium because you need to know it. It's Haemophilus. Haemophilus is the genus. Have y'all heard this before? Sure you have. Influenza. That's the spelling of the species. So Haemophilus influenzae. Now don't get this species name confused with the flu virus, because this is not. This is a bacterium. This is a bacterium. Okay? It's a bacterium. This bacteria is part of normal flora, a lot of normal flora, and it's usually not going to cause any trouble. And especially it's not going to cause much trouble now because we have, what kind of vaccine do we have? We have a vaccine. Make sure you know this vaccine. It's called the Haemophilus influenza serotype B vaccine that protects you against this. The Hib vaccine. So it's not likely that you all will have to see somebody die from this. But what do we know about vaccines right now in our country, in our so-called educated country? What's happening with the numbers of people getting vaccines now? We're having spots of epidemics, of things that are preventable. And if this one comes back, I just can't tell you, because I remember in the early 80s, kids that were dying from this. Epiglottitis, why would it be so deadly? Because if this is inflamed, what does it block?
Airway.
It's just blocked your airway. How much time do you get? 7 minutes. You keep saying 7 minutes. I'm going to promise you some people will die in 4. So you don't want, 7 minutes is going to be your outside, right? And so you've got 7 minutes for somebody to be around you that knows how to do a trach without killing you. Or whatever. And it can happen in a split second. But this is also the bacteria causing epiglottitis, is the reason that you do not take for granted when somebody is looking like they have a really sore throat, pharyngitis, inflammation of the throat, pharyngitis, that you don't immediately say, give me some swabs. I know they're going to want a strep test. Open your mouth. Give me the thank you. No, you do not do that. You don't do it as emergency professionals either. Because if that one, now it's rare because of the Hib vaccine, but it's not gone. You make sure if somebody has a sore throat, you're kind of watching them. And if they have their head tilted back with their sore throat, what would it indicate to you? You can't breathe. They're open. They don't even know it, but they're trying to keep their airway open. And if they're looking anxious, are you paying attention to that? And if they're not swallowing spit, then this is not a typical sore throat. So any really sore throat, you're going to say, can I see? Because what is going to happen before you stick a tongue depressor or put any swabs in the back of the throat, if you look back there and you see this thing that looks like a worm coming out at you, that's their epiglottis. And you're going to, if you're not in a hospital, if you're in a clinic somewhere on the side of the road, or if you're in the rescue squad, you're going to go faster. You're going to call the rescue squad because you don't want to carry them in your car. Because you would, if something happened, you wouldn't be able to get to them. Call a rescue squad, get them to the hospital, and they'll go into ICU with the trach set up right beside, ready to go, and IV antibiotics going. But the trach setup is going to be there in case they need it. You get it? Now the good news is that we've seen the numbers go way down since immunizations because people don't have any memory they think it's okay not to get immunizations now. So this is going to be one of them that we'll probably start to see numbers going back up. And you guys will be on the front line for that. So epiglottitis, it is one of the upper respiratory infections, a URI. What does a URI stand for again? A URI. That's deadly. We don't usually think of URI as being deadly, do we? Upper respiratory infection means from the neck up. Something involved from the neck up. So is pharyngitis an upper respiratory infection? Yes. Is a cold an upper respiratory infection? Yes. Is sinusitis, you remember the bones with sinus cavities? What are they? Frontal, maxillary, ethmoid, and sphenoid. Those cavities, those sinus. Is sinusitis an upper respiratory infection? Absolutely. And we don't usually, we think, you know, upper respiratory infection, stop whining, you're going to get over it. Right? You would say that. But you're usually thinking, okay, it's an upper respiratory infection. You're going to get over it. You can treat them and they'll get over it in about a week, or you can not treat them and they'll get over it in about 7 days. So I hope you heard that. But anyway, it's an upper respiratory infection. If it goes much longer than that, then people might want to get seen, right? But if it's the one, this epiglottitis is the one that is serious. And the way it's been described to me by a patient, actually a relative, that had it and that was in ICU for 1 solid week with that trach set up beside me. The way it's been described is like if you've ever had strep throat, multiply that by 100. So it's really difficult, like sore throat. So yeah. But don't put something in somebody's mouth that tells you they have a sore throat until you've really looked and seen that it's not this. Okay. All right. So all right. So we've got these structures. Y'all could kind of label them out, couldn't you? The ones I talked about, because we're talking about them. Everybody's staying attentive. Okay. So you've got this, and you know the esophagus is behind the trachea, and so we've talked about these. This is the pharynx. The pharynx means what? Pharynx means what? Throat. It means the throat. Now, there are different regions of the pharynx, and you all have had hints to this because you have heard that the eustachian tube connects the middle ear, where those little bones are, to the what part of the pharynx? Bless you. To the what part of the pharynx? Do you get to forget what you had in name one? No. So, anybody want to take a stab at that? Does everybody remember the eustachian tube? Is this drain tube from the middle ear to the nasopharynx? So the pharynx, if you look at this pharynx, this throat, there is this part that's kind of high, superior, that's the nasopharynx. Oropharynx would mean right behind the what? The oral cavity. And the laryngopharynx would mean lower, right? The lower part. So there's regions of this pharynx, and you kind of understand you can have different things going on. You all told me that adenoids are really what? What kind of tonsils? Pharyngeal tonsils. So adenoids are back here in this nasopharynx region, aren't they? That's where adenoids are. This pharyngeal tonsils here. And then you told me the tonsils that are, when you say, you see on the sides, are called what? Palatine. Make sure you get labeled tonsils if I showed you a good picture. Look up pictures of tonsils where they are, okay? Pharyngeal tonsils, aka adenoids. Palatine tonsils. And then you told me that you have a base of paratonsils at the base of your tongue. Tongue's an important organ, isn't it? What are they called? Lingual tonsils, right? So great. So we're good. We're good so far. We're kind of coming up here. We're seeing. All right. Now you have this little dangler thing in the back of your throat. This little dangling thing in the back of your throat. And what is that called? Yeah, because it's not called a little dangly thing. It's called a uvula, right? Does the uvula have a function? The dangler in the back of the throat, does it have a function?
It should.
It should have a function. The uvula does have a function. The uvula is going to function by this flap is going to function by, and by the way, cranial nerves innervate the uvula. The uvula functions by closing off the nasopharynx so that liquid and food don't go up your nose. Again, that's an uncomfortable feeling, isn't it? So that's a function of that little dangler called the uvula here. And then again, this was the nasopharynx. Pharynx just means throat. Laryngopharynx, oropharynx, nasopharynx. And then we've got this nasal cavity, right? This nasal cavity. So, so how are y'all feeling about labeling this? We added the diaphragm. What was this notch called? It was called the cardiac notch. How do you all feel about labeling the things I talked about? Pretty good? All right, so you won't have anything other than the things I just talked about. All right, make sure anything that we did talk about, you guys feel good about it. Okay. So when we think about this respiratory system, we know a lower respiratory tract infection is going to mean something from the neck down, up or from here. And we understand that they can, any of them, be serious, because even though most of these structures that we're talking about are actually just moving air, conducting air, when I say just doing that, is that vital? Yeah, of course it is. So that's very vital that they do that. Where you think about gas exchange happening, that is happening in the respiratory division, and it's happening at an area that is actually microscopic called alveolar. So I know I'm skipping around some on this, but I kind of just want to. Do y'all mind? Yeah, well, what would you say if you did? Would you tell me? Okay, so these are the regions of the pharynx that I just told you about. These are the pictures, anterior, posterior, mid-sagittal, of the structures of these C-rings. You see these C-rings, the posterior view, the cartilage, and then also the epiglottis, how important this is. Because I've gotten to this, let me go ahead and tell you this. Have y'all ever wondered how babies can breastfeed or bottle feed, whichever you're doing, and breathe at the same time? Have you ever wondered that? You've observed that though, haven't you? You can't do it, because if you tried to do it, you'd choke to death. I mean, not to death, but you would choke, right? So how can babies do that? Your textbook says something about this epiglottis being immature. The cartilage is immature. But that's not really true. That's actually a function in babies. It's not an abnormality. They have to have it like this. So what happens is, instead of in babies, like in you, where the epiglottis closes when liquid and food go through, in babies that are breastfeeding, that epiglottis is not going to close. It's just going to form a little tent, so that actually milk can continue to go down the esophagus, but air can continue to come into the airway. So what happens as the child gets about 1 year of age, and of course it varies individually, but about 1 year of age, what you'll start noticing is that when they drink, they stop breathing. You know, like we do. When we drink or eat, that epiglottis is closed. Hey, there's your sign. You can wean them. Okay, there's the sign. You can wean them. It's because they don't need that anymore. The epiglottis has now gotten firm enough and hard enough that it is actually functioning, because they should be getting food, solid foods at this time, and you definitely want them to be closed, that epiglottis to be closing. That make good sense to you guys? Okay. Anyway, so that's just an interesting sort of little thing. So I told you all that the respiratory, and I'll come back to some of this, and I'm sorry I'm sort of going around, but I just wanted to. I told you that the respiratory division, where gases are exchanged, are down here in the microscopic regions of the lungs, referred to as the alveoli, right? The alveoli. And I'm sure y'all have heard of alveolar sacs, which is a group of clusters of alveoli. And here's what I want you to picture. For every quiet breath that you are taking as an average size adult, which they call 150 pounds, an average size adult, for every quiet breath that you take, you have to for every quiet breath you take, you have about 500 cc's, mLs, cc and mL is the same thing, that would fill this bottle of air that is being transported through these alveoli and coming back. So about 500 mLs, a half a liter of air in each quiet breath. What that really means for you is that you know when you're breathing in atmospheric air. Does our air need to be sterile? No, it doesn't need to be sterile. We'll talk a little bit more about that. But we know that air has approximately, at like sea level, about 19-20% oxygen. And you would want to know that rough average. What's the rest of air? Nitrogen is by far and away the highest component, 76+%. And then you have just a little bit of the rest of the things like CO2 and, pollutants and water molecules and those things, but about 20%. So I want you to think about, of this breath that you took in, about 20% of that is oxygen, O2. And here's what I want you to be so impressed about your lungs, okay? And I want you to see in this illustration, because they do a pretty good job of it, each one of these little alveoli, it's single cell layer thick. Single cell layer thick. And on top of it, webbed on top of it, are your capillaries, blood capillaries. And we know that from the right side of the heart, the pulmonary circuit of the heart is pumping blood to the lungs. Isn't that right? And as the right circuit of the heart pumps blood to these vessels, it gets to these capillary beds here, swarming an alveoli. The blood is moving. It doesn't get to stop, does it? And what it needs to be doing while the blood is moving over, is that it picks up oxygen. And it's going to give off CO2, and it's going to continue through pulmonary veins, venules to veins, to the what side of the heart? The left systemic pump, and then be sent to the where? The body. All right, so here's what I want you to think about that half a liter and 20% of it being oxygen. On an average size person, these are microscopic alveolar sacs. You can go back to what lungs look like. You can think about your own lungs. It's measurable, the surface area of these. The surface area that has to be connected with capillaries to alveoli. It's measurable. And in an average size adult, if we laid it out, if we laid all of the little alveoli out, they would cover more than half of a football field. And in one quiet breath, this amount of air covers that half of that football field. And oxygen, if you think about the capillaries being under the sod, under the turf, there's capillaries that are also single cell vessels. Oxygen in your quiet breath moves in and CO2 moves out. Isn't that kind of fascinating to think about? Are y'all picturing that? Because that should be fascinating to you. Who's this? Okay. But thanks. Don't let me drink it. So this is what's happening within each quiet breath. Is that, and this is what has to happen for you to have enough oxygenation in your blood. So, whenever y'all hear about patients, y'all know the first rules are what? About assessing a patient. What's the first things you think about? The first things you think about, the ABCs are what? Air, breathing, and circulation, which is all related to what? Oxygenation.
It's still ABCs with the C.
I know. Well, but yeah, it's all right. But it's referring to what? I know, but what's it referring to? Oxygenation. So you've got to be able to be moving these with these. Now here's what I want to show you. This was an illustration, but you can actually take cast molds of pieces of lung biopsy, and this is measurable. As I said, it's measurable. And here's what you need to hear. You can only have oxygen exchange, see these measured little structures, where there is a membrane lining. There's only going to be gas exchange where there is a membrane lining of the alveoli and the capillary. So maybe that would really make sense to you too. So this is one little alveoli. You got this alveolar cell, one cell layer thick capillary, red cells moving across. You have to have this for the gas exchange. If you don't have this, there's no gas exchange happening. What happens when this membrane thickens because of inflammation? What do we actually call that? When inflammation causes this membrane to thicken. Do you think gas exchange can happen as quickly if the membrane thickens? Does anybody know what we call that when this thickens? When it gets fluid, more fluid is here, because what do we know inflammation causes? An excess of fluid is pulled there, right? That's called pneumonia. That's called pneumonia. And in pneumonia, with that thickening of that membrane, what is happening to your oxygenation? It's going down. Can it be serious? Yeah, obviously it can be very serious. So this is what's happening. Now, what would happen if for some reason this little alveoli that we already said is one cell layer thick, what happens if it starts being destroyed for some reason? If this little alveoli got destroyed, that's okay, because we have others, right? Think about what it should be. It's a finite, it's a lot, but it's a finite amount of surface area. If this one got destroyed, are you going to be able to get it back? No. No. And I want to talk to you just briefly about something. I've already mentioned pneumonia, so I am going to do this right now. I never skip like this. Do I usually? I do a micro all the time. So my microcontroller used to me skipping. Oh my God, are you kidding? So here's the normal amount of surface area that you would love to see. But if it's thickened, what did you say? Pneumonia, right? But what happens when air starts to get trapped in that? When air starts to get trapped, what is happening? It's breaking. These little alveolar sacs are breaking, aren't they? And you're losing membrane surface area. When you lose membrane surface area, this is actually referred to as emphysema. It's emphysema. I want you all to know that there's two main causes of COPD. COPD, chronic obstructive pulmonary disease. Two main causes, but the World Health Organization is actually, I think they've already done it, listed a third, and so I'm going to give you that third too. But the two main causes are asthma and emphysema. And the third that the World Health Organization is now calling chronic obstructive, meaning people are they're not getting good airway openings because of this, is obesity. Obesity. And is obesity a problem in all developed countries and even developing countries? Not just developed countries, but developing countries now? Yes. Yes. So causing chronic respiratory, which is putting a strain on the what? Heart, which is then leading to cardiovascular disease, correct? Okay, so I hope that you're seeing that those connections. I want to tell you a little bit about emphysema. And anybody know anybody with emphysema? Are they still with us? Yeah. All right, so I want you to know that emphysema is a progressive terminal diagnosis, is a progressive terminal disease, and the diagnosis is terminal. What do I mean by progressive?
Continue to get worse.
It's going to continue. Once the diagnosis happens, it will continue to get worse. Is there a way to stop it, the progression? No. We don't have that. We don't have a way to stop it. And when I say terminal, what does that mean? It means that if you don't die from something else first, it will progress to where it will be terminal. So that diagnosis is a serious diagnosis. What causes emphysema? Smoking. Smoking causes emphysema. A legal drug? Yes. So smoking. Now, there are ways that you can slow the progression down. What would be the best way to slow the progression down if you get it out? What? To stop smoking. And there's going to be other things too that you can do to try to conserve some of what you have. It's not just stop smoking. There's going to be quite a few different things that you should do and can really slow the progression down. But it is progressive, and I think when I show you what's happening, you'll understand why it's progressive. These are the surface areas you'd like to have, but with emphysema, what happens is it's not about being able to breathe in, it's about not being able to breathe out. So what happens, because air gets trapped, it puts pressure on these little alveoli and they pop. Just like bubbles that you see in a sink popping, they're going to be popping. And as they pop, more air gets trapped. And as more air gets trapped, it's putting more what? Pressure on the existing ones. And as the more pressure happens on the existing ones, more bubbles pop. And more air gets trapped. And more bubbles pop. Do you get what I'm saying? One of the best physical therapies for somebody who gets this diagnosis is going to be something. It's going to be twofold in how it helps. It's called pursed-lip breathing. Y'all have heard of that? I want you all to, you've heard of it? So I want you all to if y'all did this with me for very long, most of you all would feel lightheaded and probably feel real nauseous and want to be sick. But I really wish, like all young people, before they picked up cigarettes, would be maybe made to do this exercise. And this is what pursed-lip breathing is. But before I tell you what pursed-lip breathing is that can help to slow down the progression, I want to let you know about what a pulmonologist, Paul Surratt, told me long ago about this. Have you all ever, you know a regular straw, which are terrible for the environment, but anyway, you know what a regular straw is like, a regular straw, a milkshake straw. A good one. If you should practice it. If you had a regular straw and somebody put a clothespin on your nose, because otherwise you cheat, and pursed your lips around that straw and tried to breathe for 5 minutes, you'd probably be sick soon after. Because you're not moving a whole lot of air through that straw, are you? And that is how people who had asthma attacks are feeling. So every single asthmatic event is a life-threatening event. Every single one. There's no such thing as mild asthma. Okay, so that's how somebody with asthma feels. Somebody with emphysema. Have y'all ever seen a coffee stir? Have you seen a coffee stir straw? It's tiny. Do the same. Breathe through that. That's how they're feeling. They're oxygen starved. And they're panicked. And their feeling is that they need to be breathing in. But is that the worst thing that they could possibly do? Is the struggle breathing in? Why? Because they're doing more trapping. So what they need to be told is in their times of panic, because they're oxygen starved almost all the time. But in when they're not so panicked, they need to be breathing out longer than they're breathing in. And again, if you're a healthy person and you do this, it's going to make you feel sick. But this is what they have to do. So pursed-lip breathing is this breathing in calmly, normal breath in through your nose. You try to breathe through your nose if you can. Breathe through your nose, and we'll talk about why. But anyway, through your nose. But they have to practice by pursing their lips so that they can feel the air moving across their lips, breathing out twice as long. So it would look like this. And they need to push with their muscles to be able to feel the force of the air coming out. Because forcing the air out will allow them to actually get better air in. They don't know that in their panic because they're trying to go, right? But that's the worst thing that they can try to do. It's the breathing out. It's the pursed breathing, learning how to breathe out. And they need to be practicing it as often as they can for the rest of their life. Any questions for me? Okay, so this is emphysema. There is a rare form, I've never seen a person who had this. I'm sure at UVA they had some people, but I just never had a patient that I saw this. There's a rare form of emphysema that is inherited. It's an inherited genetic defect of, it's called antitrypsin 1 enzyme. But anyway, these people die of emphysema in their 30s and 40s and they would never smoke. But it is rare, rare, rare. What causes emphysema? Smoking. How many need a cigarette? Okay, that was me. Not really. I just wanted you to know that that's what's going on there. Okay, so any questions for me? So we've covered a lot of this, but I just want to go back just to make sure I'm not missing anything I really wanted to tell you. All right, so we understand that we understand the basic anatomy. We understand most of these things, or most of these structures are conducting, moving air. And then at the alveolar stage is where gases are being exchanged. That gas exchange is happening without any energy needed because they're just diffusing. It's passive diffusion. So you're not having to use any ATP to move oxygen into the blood and CO2 out into the alveoli to be breathing out. No energy. It's a beautiful system, right? With very little energy being used for breathing, which is just amazing. But it really is. So what's the functions of the nose? And this is why we want to be nose breathers if we can. You know how miserable it feels when you have a cold and you can't breathe through your nose, right? And some people can't breathe through their nose for more reasons than that. They have deviated septums, or they have some sort of structural anomaly that causes them to be, and it's difficult for them to breathe through their nose. But in a perfect world, we'd all be able to breathe through our nose. Yes.
My dad broke his nose multiple times when he was young, and he will not breathe through his nose. So his oxygen sacs are like really low.
Yeah.
And we have to get him to breathe through his nose.
Well, it always sounds like he can't. Like some people can't breathe through their nose. If he can, when somebody's forcing him to, then it might be that he just has. I mean, I thought you said he couldn't because of his injuries.
Well, he won't do it. But
yeah. So but he might not be doing it for real reasons, like an ENT, an ear, nose, throat person would be able to tell somebody, or maybe even suggest. Sometimes they can't always fix, but sometimes they can. And if somebody is having trouble with the oxygen sacs being low, especially when they're sleeping, because we understand that sleep apnea leads to so many different chronic conditions. Sleep apnea, this is why that positive air pressure machine, sleep apnea leads to earlier deaths. It's definitely, it does. Now, I'm not talking about young, but I'm talking about, I'm talking about, taking some years off at the end when somebody has like chronic respiratory diseases and stuff, and they have sleep apnea issues. It puts pressure on the cardiovascular system, which ends up putting pressure on the kidneys, which ends up putting pressure on everything. So, sleep apnea is not a good thing. Temporary stopping of breathing when you're sleeping, right? So the nose, the reason you want to breathe through your nose if you can, is that the nose is serving a lot of different functions. It's warming the air. You have incredible vascular tissue in your nose, and vascular tissue means the blood's there. And is blood warm? Huh? So blood is warm, right? And as the blood is there, it also is bringing in fluid from the blood plasma to the tissues and actually moistening the air. So it's warming. It's cleansing, because you've also got this like nice little mucousy layer. It's cleansing. It's humidifying. And when air warms, this is why you want to breathe through your nose. What will air do when it warms? And so what will that help to expand? Your lungs. It's doing that. But also the humidifying is important, because as you are humidifying the air, where I showed you all the interface between the alveolar tissue and the capillary, gases won't transfer from one concentrated area to another unless there's a fluid interface. So this is why also when you give somebody oxygen or they're on oxygen for any length of time, what have you got going to that oxygen tube? What do you know you've got? You've got a humidifier, don't you? So you've got the water helping. So that's one of the reasons, is because you can give somebody all the oxygen in the world, but it's got to be a fluid interface between those membranes or gases won't exchange. So these are all very important things. Certainly it's important that we can detect, dangers like smoke or food that's gone bad. How many of you smell your food? Everybody, you smell your food before you eat it. Do you have, is it like a little bit obsessive smelling it before you eat it? You think it is? Okay. Sometimes I do, I catch myself doing that. But anyway, that's not a bad thing. That's a self-preservation thing. Because can you eat things that have gone bad? And could that be bad to do? It can make you sick, can it? So we can pick up things like that, and it's protected. Now look, I'm not going to have you label any of this. The only reason I'm showing these pictures, we label everything, don't we? Like, isn't this just amazing what we label? But I did want to show you this philtrum. This is called a philtrum. You've got this little philtrum here. When babies are born, they're checked immediately for some facial anomalies, because we know when certain internal organs are developing in utero and what external organs are developing at the same time. So sometimes if there's ear anomalies, one or the other, the kidneys are developing at the same time. So what might you want to check? The kidneys. So you get what I'm saying? The facial anomalies are going to be really important for that, because somebody who doesn't have a philtrum, this is usually a really quick indicator of fetal alcohol syndrome. So fetal alcohol syndrome happens, obviously, when the mother has an alcohol drink, a drink that's got alcohol. How much is safe? How much alcohol is safe during pregnancy? None. Not one drink. So if you've got somebody you know who tells you that their OB tells them that they should have a little glass of wine every 18 minutes because it'll help them to relax, that's a person who needs another OB doc, because they do not have their best interest or their fetus's best interest at mind. One alcohol drink has been known to lead to fetal alcohol syndrome, and that means that individual is going to have a lifelong consequences from that. Usually mental deficits and other organ system deficits as well. And you can tell from some of the facial things. Y'all could look up other things, but this philtrum is one of them that they look for. All right. So what I wanted you to see as far as this midsagittal section of the nasal cavity is that when air moves in through the nares, when the air moves in through this area, it's going to be spread out. And it's spread out through these are referred to as, I'm not going to have you label them. You're not going to have to label this stuff, but it's a good picture to look at, because can you see the pharyngeal tonsil on the back wall of the nasopharynx? Y'all can see that, right? So this is a good picture to look at some of the structures that you are going to be responsible for. But I'm thinking about the air now. And so this air gets, in a quiet breath, gets spread out. And this is very vascular tissue, especially in this inferior meatus and conchi, because on one side, at any given time, you have erectile tissue here. You thought erectile tissue was only in the genitalia, didn't you? That's not true. You have erectile tissue, and at any one given time, one side is engorged. That's why at any given time, you can breathe out of one side of your nose better than the other. And it usually changes every 30 to 90 minutes or so, depending on you and the situation and whatever. It'll engorge on the other side. They're never engorged at the same time. Nice to be coordinated, right? But when they engorge, it's bringing moisture, it's bringing warmth, and that's doing that area, and then the other side engorges. This is why when somebody has chronic nosebleeds, it's often in this inferior conchi region, because this is the area with the erectile tissue. So they'll usually go in and try to they know where to look, and they try to cauterize it sometimes if this is an issue. With nosebleeds can happen for a lot of different reasons. They can happen because of allergies and the drying out. They can happen because some people take, and really I hate to say it, but get a little bit addicted to decongestants and over-the-counter cold medicines and, whatever. But it can really change the anatomy of nares, and so, or this nasal region, and it can lead to this kind of tissue breakdown. You can have hypertension. Why would hypertension cause nosebleeds? Yeah, because the blood pressure is just enough and this tissue's engorging that it's just enough that it starts to rupture areas, and so they'll usually go in and cauterize.
I was about to ask you that.
Yeah, that's exactly why. And so it can be an indication of hypertension. Any questions for me about that? This is a great design too, because as the air moves in, it also has to take this really kind of steep 90-degree turn. And that is going to help to encourage anything that's been trapped, like debris. Our air doesn't have to be sterile. It shouldn't be awful, but it doesn't have to be sterile. Because anything large particles are going to get trapped here in the mucus, and then it has to take this 90-degree turn, and guess what you're just going to do? Swallow it, right? But it's not going to go down your airway. Are y'all good? Everybody good? All right. So, and by the way, a nosebleed is called epistaxis. Have y'all heard that term? It's somewhere in your notes. I don't know where it is, but it's somewhere. Did y'all see it in the notes on one of these slides? So anyway, I think it might be here. So this is a nosebleed, and so that's the medical term for nosebleed, epistaxis. So anyway, and you would want to figure out, especially if somebody had chronic nosebleeds, that should be attended to and figured out. So we see the pharynx region. We know pharyngitis just simply means the inflammation of the throat, doesn't it? And what's the most common cause for pharyngitis? Everybody get this in your head. What's the most common cause for pharyngitis? Allergies. Allergies. Can you treat allergies? You can treat the signs and symptoms some, and you can, sometimes people even go to get shots and that kind of thing. But, really you kind of take care of signs and symptoms is what you try to do. But allergies. What's the next most common cause of pharyngitis? What? I thought somebody said anxiety. I was like, never heard that. Did you think that somebody said that too? It's viruses. It's viruses, viral. Can we treat viruses? No. Can't, really, we can't. We can't. Cold viruses, that's what I meant. You can treat them, they'll last about 7 days, or you cannot treat them, they'll last about a week. So you can treat some of the signs and symptoms that make you feel better, but a virus is going to typically run that course that virus is going to run. And sometimes you can alleviate some of the signs and symptoms, but you're really not treating so much the virus. And so it's going to be cold viruses, and there's several hundred cold viruses, right? So anyway, and you don't get them twice. I know you think you probably have had them twice, but you really don't, because we have specific immunity, don't we? And most of these cold viruses are very stable antigenic viruses that don't change, and so you get specific immunity. Now on the rarest, and I'm talking about single digits of cause of pharyngitis, is going to be bacterial. And the one that we think of a lot with bacterial pharyngitis is obviously Streptococcus pyogenes, which is group A strep. Y'all have heard it called strep throat, right? For strep throat, I've already hinted to you that when you have strep throat, are they treating you because they feel so sorry for your sore throat? No. You would get over that. You would get over that on your own. They're treating you to hope to prevent what? Scarlet fever, and what else that I just talked about? I think I just talked about. It's a big one. Acute glomerulonephritis, right? Which is meaning your kidneys are going to fail, potentially. Acute glomerulonephritis. Remember me talking about that in my hypersensitivity? Y'all do need to know that for the test. Acute glomerulonephritis. And they're treating you for your sore throat so that you won't get rheumatic fever or heart valve destruction. That's a good reason to treat the sore throat when it's strep, isn't it? I mean, that is a good reason. Even though most people who have strep throat would never develop any of those things, they would get over it on their own. But there are those few percent that could develop that, and that's why we treat strep throat. Yes.
Can you say the one more time?
the acute glomerulonephritis. Acute means the sign and symptoms come on quickly and they're serious. And glomerulonephritis, glomeruli are the filters of the kidneys. Nephritis are the nephron functioning units. Inflammation are the functioning units of the filters of the kidneys. Is how you would break that down, what it means. Okay. Okay. In the larynx, we called our what? Okay, I got what's on this. The larynx, we called our voice box in when you said there can be laryngitis. And you see these muscles that are involved with the vocal cords and how these muscles move and air is moving through them is how we actually make speech, right? So this motor control of speech. The trachea, we looked at. The trachea, the lower respiratory tract, has ciliated cells. What does ciliated lining of the trachea provide for us? What do cilia provide for us? What's the function of cilia? It moves substances past the cell. So the cilia in the lower respiratory tract are acting like an up escalator. Because we know we have mucus lining cells, goblet cells that are mucus cells that are trapping anything that did get through, like dust and debris and pollutants. But they're trapped in the mucus now, and that's okay because the cilia are working them up, and it gets to your glottis, and you go and you swallow it, and it's good. It's all good, right? Now most of us don't have to do that thing because it's just happening at such a great gradual pace that we never even consciously know it. But if you ever hear about somebody with a smoker's cough that early morning, just it might not be bad or it might be bad. But if you've ever heard of that, it's because their cilia are trapped with tar, and the cilia aren't functioning. They're not functioning, right? So they're stuck down. So someone who smokes has to actually mechanically force that up. And especially after they've been lying horizontal, it helps it a little bit. It helps it a little bit because it's horizontal. And so then they really have to get it up in the morning. But most smokers don't admit that they have a cough. How many smokers do y'all know that admit they have a cough? Do you know any of them that admit it? But that's usually why. And it's also why, how many of you know people who stop, this will be the last thing I promise. How many of you know people who stop smoking and they will tell you, I never had a cough until I stopped smoking. Have you ever known somebody who did that? Yourself? You said it?
I never did have a cough.
Until you
I
stopped.
never noticed any difference either when I quit smoking, whether I had the lung capacity that was better or not.
Well, we're going to test on capacity in just a few minutes. So anyway, and it doesn't always tell the whole picture, but people who stop smoking are going to have a cough afterwards for a pretty significant period of time. You know why? Because they're going to start, those cilia are going to start getting rid of the tar that's not continually being laid down on it. And as that tar is being, the cilia are starting to function again, do they need to get that tar up? They need to get the tar up. And so they are going to usually, for a significant period of time afterwards, have a cough. Now, any kind of chronic cough should be examined. That's why I said, colds and certain things, you're going to be sick for a while. But if things coughs last more than 2 weeks, people need to be checked. Y'all have any questions for me? No? All right, I'm going to stop the recording. And what we're going to do in lab, I'm going to get some models out, but I also want you all to do pulmonary function tests for me.